Hi, everyone. We're going to give the audience a few minutes to jump on the webinar, and then we'll go ahead and get started. Hi, everyone. Thank you so much for joining us today. We're hosting our, I believe this is our third webinar in our series for our Project Equity. And today we're going to be speaking about Native American communities during COVID-19. A little bit about our agenda today. I will give you a brief introduction to CareMessage in case you're not familiar with our organization. Then we'll go ahead and hand it over to our speaker today, Todd Phelps. And he'll be giving us some information and education around our Native American communities and some considerations when delivering care to Native American communities. If you have any questions throughout the webinar, feel free to drop those questions in the Q&A section or the button. You can use the chat as well if you happen to not be able to access the Q&A section. And the recording and the slides will be available after the presentation, so we will share those out via email. And for those of you that might not know me, I'm Cecilia Corral. I'm the co-founder and VP of product here at CareMessage. And CareMessage is a patient engagement platform for underserved populations. Our mission is to leverage technology to help safety net organizations fulfill the essential needs of underserved populations. We were started in 2012, and we've been focused ever since on the needs of safety net organizations and the underserved populations that they serve. We work with about 300 safety net organizations nationwide that cover over 6 million patient lives. And with COVID-19, since the beginning of March, our customers have actually sent over 12 million COVID-19 specific messages. And so it's been a really great opportunity and use of our platform to make sure that information is being delivered to patients and that our clinics are using communication as another tool to be able to reach their patient populations. And what we came to realize, and all of you that are attending today have probably come to realize as well, is that COVID-19 is not affecting all patient populations the same. There is sort of a common thread when it comes to income in terms of underserved patients, but other factors that are a part of their background are affecting the equitable or inequitable health outcomes that we're seeing tied to COVID-19. And so although we at CareMessage and communication is not going to necessarily solve a lot of the systemic inequities in our country, we did feel that there was a part for us to play in just shedding light on the racial disparities that, you know, for all of us, you know, probably know these racial disparities were here before COVID, but it is affecting communities of color today. And so today's focus is going to be on Native American communities. And so I'm going to hand it off over to Todd Phelps to kick us off for today's presentation.
Hello, everyone. My name is Todd Phelps. I'm grateful for being here. Thank you all for tuning in. I am from Rapid City, South Dakota. I'm enrolled in the Sisseton Wahpeton Oyate tribe, Dakota Sioux, but I grew up on the Pine Ridge Indian Reservation, which is not my own home community, but we're fairly similar. Went to Stanford University for undergrad, where I got my bachelor's in ethnic studies as well as psychology. Continued on to get my master of public health with a concentration in healthcare management from Columbia. Worked within the sector as a HIV Hep C care coordinator at a Native agency within San Francisco, and then moved into administration working on quality at another nonprofit in Oakland, California, and currently am entering my third year in a PhD program in clinical psychology at the University of Park. So I will be kind of giving you a review of Native American healthcare as well as health disparities and kind of some considerations to take in when you're working with Native American population. So first, we'll be starting off with kind of who is Native America and how is that sort of defined. So there are about 574 distinct federally recognized tribes. These are the individuals who have treaty rights signed with the United States government. There are 63 state recognized tribes, and so they don't necessarily receive treaty rights, but they themselves kind of have these rights and obligations with their state that provide specific funding that isn't necessarily tied to any federal funding. About 6.79 million individuals within the United States identified as Native American. However, only 1.14 million of those individuals are actually enrolled in a federally recognized tribe. 1 million live on reservation lands, and so that becomes kind of sticky, and we'll get into that a little bit later on kind of how healthcare funds through the Indian Health Services is divvied up. Because a majority of individuals who identify as Native American do not live on Native American lands or the reservations, and most of the funding goes there. So we'll get a little bit more into that later. There are 4 kind of large tribes. The Cherokee Nation is the largest. Obviously, you can see how many individuals. They're at 729,000. The Navajo Nation down in the Southwest have around 300,000. The Choctaw Nation, which is kind of like a close relative to the Cherokee, is the 3rd largest, and then the Great Sioux Nation is the 4th largest with about 153,000 individuals enrolled. The tribal enrollment is quite an interesting concept. There's certain criteria that every individual has to meet in order to become a member of each tribe, and then therefore able to get some of the treaty rights given by the federal government. This becomes a hot topic within Native American communities because most of the tribes base it off of blood quantum. So Native Americans' blood quantum have been tracked since the beginning of colonization. And so basically everything revolves around how much blood a person has, which becomes kind of a bit of a political mess for a lot of Native America because there's this concept of kind of being Native American due to your cultural value system and being really rooted in your tradition versus just having blood and therefore that being enough criteria to be a tribal member. But that's a different topic. We'll talk about that maybe some other time. Next slide, please. So a huge piece to really understanding Native Americans and sort of healthcare outcomes is looking at the systems which have been set in place within Native American communities. And so there's a huge historical context that always has to be acknowledged in order to really understand how Native American societies or communities really operate today. And so obviously most people know America was founded in 1492 by Columbus. I kind of skipped quite a few hundred years of the history to kind of look at some of these bigger highlights, starting mostly at the beginning of the 1800s. And so the big one that kind of really sparked a lot within Native American communities was in 1832 when there was the Marshall Trilogy. And within this piece that was written, this kind of brought about dependence of Native Americans in that Marshall basically states that Native American communities will forever be reliant upon the federal government in a child-father relationship, and the father being the president of the United States, and the federal government or the tribes being the child. And so that kind of set the foundation for which the relationship between these sovereign nations and the United States government operate and engage with one another. 1838, most people know about this notorious act of the Trail of Tears where I believe around quite a few thousand people had to walk from the south up to Oklahoma. It's a 2,000-mile walk, and it was rather brutal with guns pointed at them. Many people died from it. 1851, the Indian reservation system was created, and so that was kind of what brought about reservations in Indian territory, as they call it, and they were made as sort of like isolation camps, and so they kind of mirrored what concentration camps were for the Jews during the Holocaust, and so they were forced onto these lands, not allowed to leave them, and were sort of just there sitting squatting ducks waiting for the federal government to hand out supplies and food and necessities. 1862 was the Mankato Massacre. It was the largest mass execution in American history by hanging. About 38 individuals were hung plus 2, so 40 total. And that was a direct result from when the Indian system was created, or the Indian reservation system was created. The supplies of food, basic necessities were not being delivered to these reservations, and so individuals left the reservation to go seek food, which started a few wars between some of the settlers and natives, and the result was the Mankato Massacre. And ironically, there's a lot of intertwined history here with other minority groups. The same day that Abe Lincoln signed the Mankato Massacre, he also freed all the slaves. So that day and Abraham Lincoln have a very different understanding within Native American communities. 1876 was the Battle of Little Bighorn. So this was known as Custer's last stand when he took his cavalry in hoping to defeat the Great Sioux Nation. It didn't happen. Instead, his cavalry was annihilated and defeated. And that had repercussions for Native America much later, particularly in 1890, and I'll go over that when I get there. 1879, the Carlisle Indian School opened, so this was a huge movement. The slogan was "Kill the Indian, save the man." The purpose was to kind of get rid of the savage, or the traditional culture and understanding of life that Native Americans held, and tried to colonize them and adopt westernized ways. 1887 was the Dawes Act. So this act was passed because they believed by allowing this huge chunk of land, which was the reservation, to remain a huge chunk of land, it kept their communal identity intact. And what they wanted was for them to be independent individuals. And so what they did was they took up the reservation land and divided it up and said, every male of every household will get 360 acres. And from that, you will learn how to be farmers and learn how to be self-sufficient. But it was all an act to try to break down the communal identity that a lot of Native American communities have. 1883 was when Indian religion was banned, and so a lot of traditional practices were not allowed to be practiced, and if they were caught practicing them, they were either sent to prison or given some type of punishment. And that became sort of a way, with the Carlisle Indian School, a lot of Christianity was being forced within Native American communities, and this was another step to ensure that that conversion to a different religion was actually taking place by completely isolating the communities from their traditional practices. 1890 was sort of directly a result from the defeat at the Battle of the Little Bighorn to Custer's cavalry. So the Wounded Knee Massacre was when over 300 men, women, and children were brutally annihilated down on the Pine Ridge Indian Reservation. When they came to the camp or the fort, they were surrendering their guns, and unfortunately they just opened fire and killed men, women, and children. And that was kind of the way in which most of Native America thinks about that act. It's the Wounded Knee Massacre was kind of like our last fight, or our last resistance to the Native American, or sorry, excuse me, the federal government and the kind of resistance to colonization. There was a huge period where people kind of felt defeated, stayed within their reservations, and kind of just accepted the life that they had. 1924 was the next big thing, was the Indian Citizenship Act. A lot of people already had, a lot of other minorities already had their rights in place. Native Americans did not. And so there was an act passed to give them certain rights as a citizen, but at that point it wasn't all the rights as a citizen yet. And so they had these kind of uniquely define federal government rights. 1953 was the Indian Termination Act. So this is where a lot of people or a lot of tribes lost their actual federal recognition. So like I said, there was 574, but according to some historians, there may have been thousands of tribes, but you're not considered a tribe unless the federal government acknowledges you as such. And so during that time, during the Termination Act, they actually pulled or relinquished a lot of, or yeah, took back a lot of the federal recognition to a lot of different native tribes. And so that's where the state recognition comes integral, because some of the ones who lost federal recognition then received state recognition. 1956 is the Indian Relocation Act, and so this is where they took individuals off the reservation. The plot of land that they got at the for the Dawes Act, the federal government would say, well, we have this program where you can give us your 360 acres, and instead we will move you into big metropolitan areas so that you can learn a trade or go to school, and we have these systems in place to make sure that you make it. Unfortunately, they made it sound a lot better than what it actually was. These people would end up signing over their lands to the federal government, and then they would move into the cities, and there was no system set up, there was no money, and so a lot of people just lived in poverty and ultimately kind of became homeless individuals in these big metropolitan areas at that time, and then lost all their land. 1968 was when the Indian Civil Rights Act and American Indian movement took place and started, and that kind of thrived throughout the 70s. And so this was when we fought to actually get all civil rights rather than just having citizenship. So if you notice, that's almost 100 years after most other Americans had their full rights, whether they were minority or non-minority. So we are about 100 years behind actually having full rights as an American citizen. It wasn't until 1968. 1973 was integral to the Wounded Knee occupation, in which the American Indian movement went back to Wounded Knee, took it over to try to force the federal government to uphold treaty rights and get rid of a tribal president that was really inflicting a lot of trauma and a lot of harm within his own community in the Oglala Sioux tribe. And so they went there to again, form some sort of resistance and hold the federal government accountable for some of the wrongdoings that took place historically. 1975 was the Indian Self-Determination Act. So this is where the federal government sort of forced or imposed a westernized form of government within these tribes. And if they didn't move to this sort of federal westernized government structure, they would then start taking away their federal recognition. And so it put in a philosophy and a structure within the community that was inauthentic to our traditionality. 1978 was our Indian Religious Freedom Act, so that is when we were actually able to practice our religion without any type of repercussions or issues dealt to us for that. Next slide, please. So all of this is really important to really kind of contextualize Native America. So history resulted in all the tragedies that took place with the federal government and Native American communities. What it created was a Pan-Indianism culture, because we had to live with the fact that there was colonization as well as traditionalism. And so the process of trying to mitigate both of these constructs has been really at the heart of Native communities as we move forward. And when this happens, this Pan-Indianism or this shift in terms of identity happens, that obviously has an impact on your health. And there's the kind of buzzword right now with social determinants of health. And so I try to conceptualize how all of this plays into these health outcomes. And so again, as I said earlier, we've only been full citizens. Native Americans have only been full citizens for about 52 years. So we're about 100 years behind other minorities. And so this becomes a really problematic thing, because a lot of the resources in which we needed to be healthy, especially during things like smallpox and really deadly viruses were taking place, we didn't really have that set in place yet. And so we're constantly dealing with crises as they come along. And so we're still very much in our infancy when it comes to understanding and trying to integrate into Western society. The way in which the Native American reservations were set up, unfortunately, by being that child dependent on their father, as stated in the Marshall Trilogy, we have no economy on the reservation. No Native American owns their own land. So if I were to get that 360-acre plot, what happens is the federal government put all that land in something they call trust. And so we don't necessarily own our land. The federal government has it in trust and we just get to live on it. So if that becomes problematic, because if I wanted to go start a small business, I couldn't use my land as collateral to get a loan from the banks or the federal government to do so. And so that has perpetuated the poverty within Native American communities because the laws, the American Indian law and the treaty rights and the way in which they structured these reservations, which were really kind of constructed to be concentration camps historically, have resulted in perpetuation of poverty because it is rooted in the dependence on the federal government for survival. This becomes problematic because obviously low socioeconomic status, that leads to limited choices and opportunities within these communities. And while we do have the Indian Health Service system, that is subpar to what is necessary for these individuals. And so healthcare generally is not really there. Along with the lines of looking at the historical timeline comes historical trauma. And so what happens when historical trauma takes place is there's a huge distrust to anything that is not known within the community. And so this becomes problematic because then that forces behaviors to change. And so a lot of people lack seeking out resources when they actually need it. And it becomes a constant state of crisis. You don't get help until you're actually ready to die. And we see that within the healthcare system. People aren't coming in to get the help they need until it's too late. Rather than preventing something from happening, now we're stuck with creating these traumatic diseases or these chronic diseases. Along with the history comes the defiant child, which they kind of feel like they need to revolt, and there's a lot of resistance within Native communities, and it's a huge resistance to colonialism, and that I think is very unique to Native Americans because of their political status here in America as being the original nations of land. And so with that comes certain risky behaviors. When you want to kind of revolt against the powers that be, that can cause certain antics or certain behaviors to come out that may not be helpful to the individual, community, or society at large. And so this comes with heightened risk for health problems. And a lot of this kind of defiance really ties into maybe some of the larger health outcomes within Native communities. And I'll go over that a little later. There's a lot of US unresolved grief. And so I would say that this becomes more problematic in areas where tribes are flourishing. And so, for example, in South Dakota, there is still to this day a lot of issue around the Native American communities defeating Custer and the Little Bighorn. That's still ironically a huge topic back here. And there's a lot of unresolved grief on that side because it is the only time the US military has ever been defeated in history. That was the only time the US government has ever lost a battle. And so there's a lot of grief there still and a lot of hatred and anger towards Native Americans, especially in some of the more conservative states, which then results in systemic discrimination. Misconstrued cultural identity, as I said, Pan-Indianism has become a thing in Native American communities, and we're stuck in this constant battle of holding on to our traditional selves while living in a culture that is quite literally the opposite of how we used to be. And so there's a huge internal battle that we carry as Native Americans of trying to make sure that we're remaining authentic while living in a system that is not our own. And so what ends up happening is there's a divide and conquer mentality within our own community. It's the point at which we actually internalize the oppression and start oppressing our own communities because we believe there's certain individuals who operate different from another leader. And so what happens is we have different leaders or distinct leaders within the community doing different things, and it causes a lot of tension internally. Next slide. So health outcomes compared to all races, I just kind of wanted to highlight some of the larger things. So diabetes is a huge, huge issue within Native communities, which obviously ties to COVID right now. People with diabetes are dying at higher rates when it comes to this current pandemic. And we have a 3.4 odds ratio for diabetes, so extremely, extremely high. Alcoholism is at a 6.6 odds ratio, and that one is always just a little touchy within Native American communities because there is the stereotype of the drunken Indian. But there is obviously some issue with alcohol within Native American communities because it is exorbitantly higher within our communities. Liver disease is at 4.6 odds ratio. Homicide is 2.1 odds ratio higher, and then suicide is 65% higher. So these are kind of the top 5 things killing individuals prior to COVID within our communities. And I kind of conceptualize things as somebody going into clinical psychology. Everything kind of revolves around mental health, and I can kind of talk to that a little bit more on the next slide. But as you can see, a lot of these things are related to the perpetuation of alcohol use in our communities. So diabetes obviously can be an effect of too much consumption of alcohol. Liver disease is obviously directly tied to alcoholism, and cirrhosis. A lot of people who have been committed or who have been killed within Native communities were at a bar in public under the influence. Not to say that their death was right, obviously, but there was alcohol involved in a lot of those situations. And trying to think of the statistic when it comes to suicide, but it's quite ridiculously high when it comes to alcoholism. There's want to say around like 70% of all suicides within Native American communities happen while people are under the influence. So there's a lot of interconnectivity there when it comes to health outcomes. And I'll go a little bit more into how history, historical trauma, and all of that, and all health outcomes are perpetuated by things. We do have the Indian Health Service system within Native American communities, which was a treaty right given for my people, for example, the 1868 Fort Laramie Treaty. But as you can see, it's probably not the best healthcare system for a high needs population. They only get 50% of the funding actually needed to adequately address societal health problems in communities. So they're already low budget. It's really, really hard to get people to want to move to these communities, which are highly rural, highly isolated, very, very different from mainstream America. And so it's hard to get the people to go and work in these sites, particularly because education is not really a thing within Native American communities. It's very rare to go on to get the education necessary to really work within the community, especially within the healthcare industry. It's all around sort of a problematic system. There's a high level of negligence. There's a high issue with funding appropriation, and there's a lot of issues with there are countless stories of healthcare providers not doing probably the things with the best intent of the community. And that's kind of taking place even now with some of COVID and some of the stories I'm hearing locally here with our Indian Health Service here, that people have been getting diagnosed with just pneumonia, and then months later, after almost dying, going in and getting tested COVID, and then finding out it was actually COVID and not just some sinus infection. And that's kind of just been the history of our people. Even prior to COVID, things like that would happen, is people would go in, say they're feeling sick, they would give them some Tylenol, just saying that it was just a cold, and then it wasn't until months later that person passed. What actually was going on with the person was happening. Funding appropriation, I tied that. So most Native Americans, they say about 50% of enrolled members within a federally recognized tribe live off the reservation. But when it comes to the Indian Health Service budget, only about 1% of all that budget goes to urban health clinics that support Native Americans. So we have this huge issue with Natives living within cities who don't have adequate resources when it comes to their health. And unfortunately, that's just kind of the setup, because the reservations are really kind of ground zero when it comes to Native communities, and there hasn't really been so much of a push there to change the way in which funding is appropriated within the Native community. Tribal self-governance. So there is a program where tribes can actually take over their healthcare system on reservations. So For example, a tribal council can say, we want to take over our clinic. So what happens is the federal government has an algorithm, a formula, where they say this is how many people they have. They plug in some numbers. Each person should get this much money for the year to give them the healthcare they need. So then what happens is they say, we'll give you 5 million because according to our formula, that's what you would need to take care of your community. They cut a check to the tribe gets that 5 million, and then they do their own healthcare system. Again, this is really great. It really is rooted in kind of this idea of tribal sovereignty. However, as I said, we have leaders within our own community where we have learned to divide and conquer, and people have different agendas within our community. So what happens is that operation gets flawed and funding may not go to where it needs to go. It may be spent on things that are not even related to healthcare system, because once that check is cut, the tribe has full autonomy in how they choose to spend it. So internally as a community, a lot of leaders have swayed the importance of healthcare or used funding in different ways that shouldn't. So again, healthcare within Indian country is just all around a problem. Next slide. So again, overall issue for Native communities from my perspective is, we're stuck in this system of oppression. You look at the history, you look at the current context, and you look at the healthcare outcomes, and all of this is tied to oppression. And so again, alcoholism, a huge problem with the Native communities. So some of these questions I just ask people, and these are the realities of the situation that most people in Native communities live in. So what happens when the community pillars for support become uncaring or uncompassionate? You learn how to self-medicate. And so if there's no job opportunity, if there's no economy, what are you going to do to preoccupy your mind if you're just sitting at home most days? You're going to probably just drink and pass time. And so what do you see when you see your own culture having to change and it's not necessarily changing for the better? You're going to disengage with that culture, and then you're going to preoccupy your mind. And then it continues to just be this cycle of oppression, and then you're dealing with stereotypes and discrimination within the community as well as outside of your community. You're living in a culture that is not your own, and you're forced into that culture, and there's no way in which you can remove yourself from it. And then also when it comes back to that Marshall trilogy, understanding of child-father relationship between Native Americans and the federal government, when they don't provide those basic necessities as our parent, metaphorically, what happens? You become hopeless. And so this was one of the things that really kind of perpetuates that idea of being hopeless, and that people just don't care, particularly the federal government. One of the health centers asked for COVID-19 supplies, and instead the federal government, FEMA, sent them body bags instead. And so what kind of message are you sending to that community when you do something that negative, as people trying to help other people live, and this is what they get in return? And so that hopelessness ties into the self-medicating, it ties into the suicide, it ties into risky behaviors. It's all there, and it's all because of systemic oppression. Next slide. So the COVID-19, how does all of this play into our current context with this pandemic, and without really knowing how much worse it's going to get in the future as we continue to open our states back up? So obviously, I'm sure many of you are aware the Navajo Nation now has the highest US infection rate, and it's kind of become the new ground zero. It's actually surpassed the infection rate of New York City. A couple days ago, there was a post, I believe it was the New York Times, who wrote a piece on this Navajo teenager who kind of made, I can't remember if it was a TikTok or a Snapchat or Instagram story, but he just really reflected on, one of the most powerful things coming from that is we just want to be seen. Everyone's talking about New York, everyone's talking about all these hotspots, but our nation, our community is the one that's being hit the hardest, and we're not seeing the resources we need. We're not seeing the highlights that our community needs in order to feel like we are cared about, and that was really quite powerful for today. One reality that we all have to deal with within Native American communities, a lot of healthcare workers won't ever come in contact with Native patients. Again, we are such a small portion of the United States. population at around 2.6, 2.9%. And a lot of those individuals live on reservations, which is an isolated community. And most of those people will go to a native healthcare agency. There is one within a metro. And so some considerations you can take are, what can you do if you come into contact with a native patient? And so right there, the Navajo teenager said it. See them for who they are, and see them for their history as well as who they are in that room today. Ask about their cultural significance. Some people are highly cultural. Some people, they're disengaged with their culture because of the historical trauma and the oppression within their own community. And a huge question that healthcare workers can really ask is ask about traditional shamans. Do they visit them? Within my own community, the traditionalists, they get the diagnosis from Western healthcare workers, but then they go get the healing from shamans. And so really understanding what your role is, if you're just the diagnoser, respect that, and then let the healing come from somewhere else, and basically track and monitor the health outcomes based on their form of healing. Another thing is just validating their experience. Natives have lost a lot historically, and they continue to live in a state of chaos for many. And living within the genocidal culture that was kind of forced upon our communities is a never-ending trauma that we live with day to day. And just acknowledging that really brings a sense of power to that individual. Honesty and transparency are obviously at the root of a lot of things within Native communities, and that all stems from distrust with people not from our community coming in as well as within our own community. And so it's okay to let them know that you lack a lot of cultural knowledge, but giving them the opportunity to learn more about it and how it plays into their life and how it plays into healthcare is really, really vital to ensuring you have a high retention. Understand the context that they live in and provide feasible recommendations. This became a huge thing. I had to really advocate for diabetics on my reservation because the healthcare workers kept just being like, eat more fruits and veggies. That's all you need to do. Don't eat the sugar. Don't eat. And I was like, but we live on a reservation where we don't get fresh food. So how are we supposed to eat fresh food when we don't have an economy that provides fresh food and we have to drive 2 hours away to get fresh food? So really kind of helping them game plan and think through some of these societal barriers set in place is really, really pertinent to seeing the health outcomes we want within these communities. From a distance, as I said, most people won't work within a Native community. Is, you see something about them, help them being seen, share things on media to spread word, to let them know kind of what these communities are working with and how they're being treated. One really easy thing is reach out to a nearby tribal clinic and just send words of encouragement. That idea of being seen and being validated is so crucial to especially the Native workers within these systems is really, really important because they start feeling hopeless, and knowing that someone from hundreds of miles away sees them for who they are and what they're doing really helps them keep going when we are in a constant state of crisis. Institutional emergency partnership, UCSF sent workers from their hospital down to the Navajo Nation to work, and they've been there on the grounds working and helping them combat COVID-19. So bringing that to your own leadership in the institution you may work in and say, hey, look at what UCSF did. Can we do something similar? If leadership says no, then possibly offer teleconsulting. A lot of things that become problematic is, like I said, operations become flawed within Native communities because we don't have the resources necessary. So what we need are those intellectual minds to come in and say, given what we have, given what we're dealing with, and given where we need to be, this would be the most optimal way to work within the community without having to actually step foot there. That could be really, really quite useful within Native communities. I believe that's my last slide.
Thank you so much, Todd, for enlightening all of us and sharing so much information, so educational. And with that, we'll kind of just wrap it up before we open up for Q&A. But, on the CareMessage side, one thing that we've been thinking about is we're looking at, all of this data of how, COVID-19 is impacting the Native American community as well as the Black and the Latinx communities as well. what we felt, our small piece and contribution as a patient engagement tool is around communication and hopefully helping our health centers, whether they're tribal health centers or other health centers that reach Native American communities, distribute information and just communicate with their patients. Text messaging is really at the core of what CareMessage does. It's a very accessible tool and just an easy way to reach an entire patient population and help clinics collect data as well. I wanted to share just a few examples of what some of our Native health centers have sent out and how they've used our product, both to help provide education around the status of what they're seeing with COVID-19, education around hand washing and wearing face masks, but also another really important thing that I think Todd alluded to, which is just building community. We do have a health center that's using Zoom to bring their patients together and just build that community in a remote way, just trying to help in any way that they can with providing that support that I think is very needed right now. So these are just some of the creative ways that some of our existing tribal health centers have been using CareMessage, and something that we hope to see grow over time as we do a lot more outreach towards the Native American community to ensure that they have tools in place and tools available to reach all of their patients and help support them during this time. And so just as a quick note, and we'll wrap it up after this, CareMessage Lite is a free CareMessage version that's available to any safety net organization. It's free at least for 60 days, but there's no long-term obligation, no form of payment is collected, and there's no obligation to purchase CareMessage after the 60 days. It's something that our health centers, as they sign up to use CareMessage, if there's a need to extend that, those 60 days, if the need continues, we are extending that for longer than 60 days, but it's something that allows healthcare organizations to start using our free messaging platform to send either one-to-one communication to patients. That's really helpful for case management, providing very direct resources, as well as messaging at a population level for broader education, or a lot of our clinics have also used it for sending links to other types of online communication that they want to have with their patients. We did also make a lot of our resources available for free. So if you happen to use a separate type of messaging system, you can access our free messaging library, as well as some videos that we put together to help explain what telehealth is. With this transition, a lot of our health centers have been transitioning to using telehealth during this time, and we felt it was very important to provide education to patients that might be using it for the very first time and might not be familiar with some of the applications that our health centers are using. And so we created some messages that are free to use. They're on our YouTube channel, and we will send these slides after the presentation in case you don't have a chance to jot down these links to our resources. And with that, head and open it up for Q&A.
Hi, everyone. My name is Christine Chang, and I'm the Strategic Partnerships Manager here at CareMessage. Go ahead and please feel free to submit any questions that you have for our two presenters. I will be moderating. We have a question for Todd, and it reads, have you seen successful examples of digital health solutions that have focused on the Native American population?
So digital health is really quite new to Native America. They're trying to deal with the fact that a lot of Native Americans do not have access to digital health because they may not have internet connections, they may not have cell phones. And so a lot of those models are just now being integrated, but a huge component to that is having the technology necessary in order for it to be successful. And so a lot of times it becomes difficult because that technology has to be provided to the individuals, and a lot of research grants, things like that, don't include that into the costs of things. And it's been really, really difficult to kind of have individuals who are trying to do research within Native communities include that and advocate for why that part of the budget needs to be within the budget. But now there are models being tested now. I know one, for example, on my reservation here in South Dakota, they started a mental health component to telehealth in which they provide cell phones with access to the internet and Wi-Fi and things like that, so that the individuals can talk to counselors through text-based messaging. And we don't know the outcomes yet of that specific project because it's currently in place. I think it started maybe a year or two ago. But those types of models are just now starting to make it to Native America because we've been kind of dealing with this component of just the lack of resources and the research needed to test the efficacy as well as effectiveness within these.
Okay, well, with that, thank you everyone for joining today's webinar presentation. You will receive a recording of today's presentation to share with your colleagues. And if you have any questions, please feel free to get in touch with us. The email to reach back out to CareMessage will be included when you hear from us tomorrow. Thank you again, Todd, for today's illuminating presentation, and wishing everyone a really great rest of your Wednesday.